Welcome to the podcast. This is the Medical Brief powered by Surgeon. I'm Dr. Ankit Patel. This is Dr. Brian Schmutzler, Dr. Jeremy Heffner, and we are rejoined by our special guest, Dr. Jerome Adams, our country's Surgeon General from 2017 to 2021. We got to know you very well in our previous episode. We got to know about the work you did, the transition from your career.
And I didn't scare you all away.
You did not. From your career to becoming our Surgeon General, and some of the things that you learned and grew from that experience. We have a lot to discuss in this episode. We're going to shift gears to talk all about COVID. Mm-hmm. And so there's a lot to unpack there. You do this very well in your book, Crisis and Chaos. Tell us, as best you can, the first few months of when things are starting to roll out. What was that experience like as you were learning something new every day, every hour? And how are you going to share that knowledge with the United States?
Well, I'm excited for this conversation. And as you mentioned, I did write a book called Crisis and Chaos describing this. And a lot of what I do is walk people through that time so that they remember, because it's easy to forget. It's easy to say, okay, forget that happened. Forget that we didn't know whether to bring in our mail. Mm-hmm. Forget that we didn't know whether or not we needed to wash down our groceries, with disinfectant before we brought them into the house. And then help them understand the information we had or didn't have at the time, and then the challenge of making policy decisions and communicating those policy decisions. So the first thing folks have to understand is that every single year we have multiple potential pandemics that occur. Every year, every winter season, there's some new virus that pops up somewhere around the world. And we go, oh, is this going to be the big one? Is it not? The biggest one we'd had before COVID was Ebola. Mm-hmm. And we lost our minds over Ebola, even though we only had, 9 total cases. Sure. In the United States. Look at all the turmoil, all the investment that we had because of Ebola. We got lucky, quite frankly, that Ebola was so incredibly deadly. And we're talking mostly to a medical or medically inclined audience here, but the more deadly a virus is, the harder it is to spread, because you don't want to kill all of your hosts when you're a virus. And Ebola is symptomatic. You can see it coming. So I'll wrap up really quickly here, and then we can explore any part of this you want to. But one of the biggest challenges we had with COVID was that it was about 50% asymptomatic. So when you can see a virus, if one of us had the flu right now, we would know it. We would know it. And with COVID, one of us could have COVID right now, and there's a 50% chance we wouldn't know that person had COVID. So it made it incredibly hard, and it was very different than any other virus we dealt with before. So it impacted the recommendations we made. With flu, our recommendations are, if you are sick, stay home. Yeah. That was a recommendation for flu, and wash your hands.
3 C's.
Yeah.
3 C's.
Cover, contain, and clean. And so the challenge is that this was it was a once in a century virus that was very different in the way it behaved. It was more airborne than what we are accustomed to, and it was asymptomatic. And we were hurt by the fact that China was not forthcoming with information. They knew in 2019 that they were seeing human-to-human spread. They knew in 2019 that it was likely asymptomatic. We did not know or understand that until late February, more so March, April. And so we made a lot of policy recommendations early on that were based on how we thought this virus was going to behave, because every virus we'd seen before was going to behave like that. Even when Trump said it's all going to just disappear. Every year we have multiple potential scares, and they typically do just disappear.
Usually about spring break time, right?
That was legitimately our experience. And so it made it very challenging. New virus, lack of information about it early on. And then the third challenge is that we're trying to make policy recommendations in an incredibly politically charged environment. And I think folks don't appreciate that. Ebola did not happen during an election year. You had a once-in-a-century pandemic occurring during what was, at that point, the most contentious presidential election of most of our lives. And guess what people forgot about? We also had a social justice movement that was unlike anything anyone had seen since the 60s. And so it made it very difficult to have rational binary conversations about all sorts of things, from whether you should go out and vote, to which communities we should be focusing on, to whether or not you should trust government.
Yeah. And that recommendation you're speaking of, the biggest one, is really the mask usage. And so, what we learned about how it was spreading changed your recommendations from earlier on to later because we learned new information. And I think what's one of the things that public doesn't always understand is that our opinions may change based off of the information we have at the time we have it. And so we can only share what we have with what knowledge we have. And so tell us about the change of the recommendation from the type of mask and who was wearing it, and how that really kind of shaped because the country's usage of masks, who was supposed to use it, who was not supposed to use it. Share a little bit about that.
Well, you're being nice to me right now. I famously put out a tweet that said, please stop hoarding masks, leave them for the healthcare workers. And I talk about that in my book, and we don't have time to go through it. Again, I encourage people to read the book for the full story. But what you need to know behind the scenes about that is we had never in history told the general public to wear masks before. That is number one. So to tell people to wear masks would have been a tremendous and fundamental change in public health and in medical recommendations, to tell the general public to wear a mask. So we had that history behind us. What we told people, again, was if you're sick, stay home. But we didn't know about the asymptomatic spread. We also, at that time, were talking about N95 masks because it wasn't even in anyone's psyche to go out and wear cloth mask or surgical mask. And then you also have the problem of, am I protecting you by wearing a mask, or are you protecting me? And we know that, for instance, cloth masks work mostly by me wearing it to protect you versus me wearing it to protect myself. So you had all of that. You had limited information. You had the legacy of history going on. And then you also had resource issues. So when I told people not to wear masks, that was because New York City was literally imploding. We were using cold storage food trucks to store bodies because they were piling up. The hospital workers did not have enough medical masks, and people were hoarding. Remember when people were hoarding toilet paper? I mean, they're just hoarding all sorts of stuff. I mean, and if they could get their hands on these medical masks, they were hoarding them. And so as Surgeon General, I was faced with the question of, okay, healthcare workers do not have the tools they need to care for sick patients. And everything I know and have been taught in public health and in medicine, it tells me that the general public will not benefit from using these masks, and that they don't even know how to use them correctly. And so I need to tell the public, you all need to stop hoarding these so that they're available for the healthcare workers. And as you mentioned, science isn't about being right. Science is actually wrong more than it's right. But what science is about is a process of saying, okay, what do we know right now? And what is the most educated hypothesis we can make right now? And then let's go out and test it. Well, the challenge when you're a public policymaker in a pandemic is you're testing your hypothesis on the general population. So we made the best possible recommendation we could at the time to try to protect healthcare workers and, in turn, the patients they were caring for. And we had little reason to suspect that recommendation was going to harm the general public, because we'd never told people to wear these types of masks before, and we didn't have enough supply to make that recommendation. Once we found out that we were seeing high degrees of asymptomatic spread, we said, we were wrong. We need to change our recommendation, which is exactly what science is supposed to do. But as I mentioned earlier, you're caught up in this political milieu where folks want to say, gotcha. See, you can't trust the government. You can't trust Fauci. You can't trust the Surgeon General. They're lying to you. And maybe we'll talk about this a bit. But like I said, I don't think people appreciate how much politics was part of this. If you look at the polling numbers, and people forget this, at that time, Bernie Sanders was polling ahead of Joe Biden for the Democratic nomination. Biden was getting his booty spanked by Bernie Sanders at that moment. But Bernie Sanders had a heart attack in late 2019. So Bernie Sanders didn't want to go out there and talk about all the dangers of COVID because that would have highlighted that he was a older person who just had a heart attack. That would have hurt him. And so the Biden team noticed that the more they started to talk about COVID, the more he polled better against Bernie Sanders. It originally wasn't being politicized as Republican versus Democrat. It started to be politicized as Biden versus Sanders. And he started to poll further and further ahead by creating this narrative that this is an existential threat to everyone out there, and you're all going to die if you don't elect me, and it's being mismanaged. And then and he pulled ahead, won the Democratic nomination, and that narrative continued. And I don't say this in any way, shape, or form to defend Trump. Trump then went the 180 degrees opposite angle of it's all about nothing. This is all much ado about nothing. And as we have talked about earlier, the answer is not black or white, it's gray. Yeah. It's not. It's all about nothing. It really was a once-in-a-century pandemic that killed over 1 million people. This was truly, in any other situation, would have been bad. And when you look at the rest of the world, no one else handled this perfectly. Lots of people, the only people who handled it well and didn't lose a ton were countries like New Zealand, because they're islands. Right. And they literally did lock down. They literally did close down. And they were able to because they are an island. But a lot of challenges that we had. And then we had communications challenges. I told you in our first podcast, I was running a 6,000 person public health service commission corps when I was Surgeon General. I didn't even have a full-time communications person. I had a half of an FTE as a comms person. And so I'm trying to run a 6,000 person agency, help coordinate this response, be at the White House and brief people, and then fire off tweets in between meetings to communicate to the public. So a lot of challenges that we break down in the book, but I just wanted to throw them out there so that folks understand why the communication seemed haphazard. We were getting bad information in, it was politicized, and then we didn't have communications experts helping us tailor the perfect message for the public.
So one thing I wanted to ask you, and we've talked about this multiple times before, so China was not communicating with us. What kind of communication did you have with other countries around the world, other health departments around the world, all that sort of stuff, to be able to craft a response globally, not just nationally?
Well, again, you're being nice here too. There's a big debate going on right now about the WHO. Yeah. And I again, it's not black or white. It's gray. It is absolutely true that China withheld critical information from us that would have changed our policy recommendations and saved lives. It's also true that the WHO is the entity that most people think of as being responsible for facilitating and enforcing that transfer of information. So, a lot of people are understandably upset at the WHO and feel like we didn't get our ROI for all the money we're sending them in terms of the help that we needed to mount an appropriate response. Now, we can debate whether that's true or not, but you can certainly understand why people perceive that to be the case. It's also true that diseases don't respect borders, and we simply cannot keep the United States safe if we don't have an open line of communication and cooperation with other countries. There's no disease on this planet that is more than a day's plane ride from your front door. Amazon can get you a package from China to your front door by tomorrow. They can also get a virus from China to your front door. We can also get a virus from China to your front door. Amazon, don't sue me. I'm not blaming you all for the pandemic. And so we need that international cooperation. And so to answer your question, it's critical moving forward that we have international cooperation so that we understand what's going on and also so that we can stamp it out. We talked about Ebola earlier. I'd much rather help Africa control Ebola in Africa than wait till we start seeing cases pop up in the United States and try to deal with it here. So we're at an interesting point where I understand the frustration that the public and the president and many folks feel. I understand why people want to hunker down, but we're in a global economy and a global society right now, and that just is not the way infectious diseases work.
I'm going to change subjects a little bit. This is actually a personal question I've had since the pandemic. I always had the luxury of being on the front line of it, the bad side of being the front line of it, but I ran the COVID response for my hospital back when it first started. And the problem we ran into was testing. And it's still to this day, it boggles my mind how the U.S. was unable to provide testing to us. And so it left us in a position where I would get phone calls like, does this patient have it or not? We have no testing. It got to the point where the College of Radiology wouldn't allow us to even use CTs or anything to make that decision. So we're basically flying blind. And if I make the wrong decision, I put a patient on the floor, the nurses are at risk. If I put them in the COVID unit and they don't have it, now I'm putting the patient at risk. And yet everybody's staring at me and saying, how do we know? And I say, I don't know. Mm-hmm. And you look around, we're the richest country in the world. We have this supposedly amazing medical system at a bureaucratic level, at a federal level, at a state level. And yet we weren't able to actually do testing at point of care testing for months. Yeah. I mean, and it was absurd, and yet I feel
it was literally almost over a year before we could do legitimate point of care testing, because we also had the challenge, to your point, of the fact that the testing we were developing was PCR testing. So I get a sample today, I find out in a week or two, a week if I'm lucky, sometimes 2 or 3 weeks, whether or not the person is positive. How does that help me make clinical decisions or public health decisions? It doesn't. And so you're right, and I talk about this in the book. The broader point is you can't make good decisions without good data. And for many reasons, we did not have good data. So my version of your story is I had to brief the President of the United States, and he said, how many COVID cases do we have right now? I said, I don't know, Mr. President. He said, how many people are on ventilators right now? I said, I don't know, Mr. President. He said, well, how many ICU beds do we have? I said, I don't know, Mr. President. And then in typical Donald Trump fashion, he said something not so nice to me. But that was the reality. To your point, we were flying blind. And so I also want people to understand, right now, there's a lot of conversation about cuts at the CDC, at the FDA, at federal agencies. And I'm on record as saying, I think these blunt cuts are going to hurt us. We need to use a scalpel and not an axe, because otherwise we're going to do more harm than good. But that said, I also want people to understand the frustration that the president and his administration rightfully feel towards some of these agencies. So to your point, the CDC with Ebola also, I said Ebola was our last example of this. The CDC, when a new virus pops up, they typically require samples to be sent to Atlanta to be tested. And that's the way we did it for Ebola. I was state health commissioner during Ebola. We would get a sample, suspect patient. The sample we'd have to identify the patient. The sample would go from the hospital to the State Department of Health. We'd send the sample from the State Department of Health to the CDC. The CDC would test it and then give us a result. That's the same thing we were doing in the early days of COVID. And so part of that is that we don't have the capacity at the local level to do all these new tests. And so at some point you go from, is this going to be the big one or not, to, okay, now we need to come up with a different plan. So I talk about this in the book. We didn't have the infrastructure from a personnel and thinking standpoint, and also from a resource standpoint, to pivot from okay, this is small enough that the CDC can handle it, to we need to expand. That's number one. Number two, there was, quite frankly, some hubris and some mismanagement in terms of our developing of testing at the CDC. So Trump is understandably frustrated with the inadequacy of our ability to stand up testing. We also, and this is something we are always dealing with as physicians, as folks interacting with the health system, we have some of the highest safety standards in the world. And that's a good thing. But the higher the safety standard, the slower things move. And so the CDC, if they make an error 1/1000th of a time, then people go, see, you can't trust the CDC. And so they didn't want to put out a test or let other people do a test until they felt 100% confident that test would be acceptable. Other countries very quick, went out and said, okay, well, this test is 70, 80% accurate. That's good enough for us. And their public would accept that. Our public would not. So I guess in summary, I would say we do need to improve our crisis response at the CDC. The CDC was not meant to respond like that. It was meant to respond, to think, to collect information, to respond slowly. So that needs to be adjusted. And I talk about things we can do in the book to do that. But we also have to understand that your expectations need to change in a crisis for safety versus efficiency.
I think I'm going to push back a little more on that, because if you go back, the Imperial College study came out mid-March, and anybody that read it, I mean, as a critical care doctor, I said I read it as soon as it came out. It was probably the scariest document I've ever read. I mean, if you go in the data, what he was looking at, his projections were off the chart. You're looking at hundreds of beds, or 100 patients per bed in the Western world, and it was going to be absolute chaos. And yet, but I think it was about a month later, Ferguson comes out and basically says, look, they tested all of Iceland, and like we see that it's probably not going to be what we thought it was. And the R value shifted dramatically on the repeat testing when they actually had testing. But they tested all of Iceland, and we still didn't have access to tests. And so I go back to, how could we, as a country, how did we get to the point? I mean, I can understand you're saying the CDC the way they are, but I think that the reason that a lot of the Trump supporters, even today, or a lot of people that are on that side, are like, look, the government failed us. I mean, it absolutely failed. If you were on the front line, or if you weren't in the big cities, we weren't going to get remdesivir. We're not going to get anything. And then the article from Lancet comes out and basically shoots down hydroxychloroquine, which we can have a debate on that one way or the other, but the reality is that ends up being withdrawn. So now so I'm on the front line. I can't trust our academics to publish legitimate data. I can't trust our government to provide us with the testing. And we're supposedly the most advanced country in the world, and nothing that I'm looking at is working. And so why should we support government entities that failed us across every way we looked when it happened?
Well, I mean, and so that brings us back to the baby in the bathwater question, and the black and white versus gray. Our government failed us, and the CDC and the FDA still are the gold standard worldwide for how you do things, and they also don't do them as fast as other countries can. I think one of the challenges that people often forget about, and you brought up Iceland. We were talking about Ireland earlier. Ireland is the size of Indiana. The United States is a lot bigger than even what we appreciate. It's a lot different. It's a lot more diverse. One of the points I bring up that is a challenge is New York City was literally imploding. Tony Fauci and I were getting calls from colleagues saying, we don't have PPE and we're trying to work in the ICU. I mean, and bodies are piling up. And that really was happening. And at the same time, we had colleagues in Montana who were like, I haven't seen a single case. The United States is big, and it's very hard to create policies that apply to everyone. It's also harder to allocate resources, or to have enough resources. We didn't have 350 million tests to test everyone in the United States, and we didn't have the resources to actually go out and actually get them tested if we wanted to. So a lot of the politics we were dealing with was who got what. I talk in the book about how Governor Cuomo in New York literally strong-armed the federal government into giving him ventilators that he did not need. And these governors, they're doing it for the sake of their individual states, but in some cases they were creating fear and consternation to create political pressure so that they got resources for the hypothetical scenarios that they were hearing about. Final point I'd make is these projections. Do you go on the worst case projection? Do you go on the best case projection? Do you fall somewhere in the middle? That's another political and communications challenge, because one study's telling us this is going to have an incredibly high case fatality rate. Another study's telling us it's going to be fine. And we're looking at studies again from Iceland and from China. The United States is not only big, it's more diverse than any of those other countries. And so we're still learning about COVID. We still don't know why you can take a perfectly healthy 20-year-old, remember the MMA fighter who went from being one of the healthiest people you can ever imagine to being on a ventilator and being down 100 pounds from his ideal weight. Tony Fauci, I'll never forget this. Tony Fauci has been doing virology for over 60 years. No matter how you feel about him, he is one of the foremost virologists in the world. And I'll never forget him telling me, I have never seen a virus like this. I've never seen a virus where it literally, one person can get it today and not know it. One person can get it today and have what's like a mild cold for a week. Another person can get it today, be on a ventilator in 48 hours, and be dead by next week. And all three of those people on paper look the same.
It was even crazier than that. I want to add that
you're a critical care doc, yeah.
Well, it was you would have a patient come in, and I say it got to the point where they're having a PE or they're having COVID. They either fell and had trauma, or they had COVID. They have a broken leg, or they have COVID, because it mimicked everything. Mm-hmm. I mean, you had symptoms that mimicked everything. They had pain in ways you've never seen, and each variant would come through, and it was a whole different world. And so, I mean, you're right about 100% right about that.
And so it made it hard to make clinical decisions, to make clinical recommendations, to make policy decisions, and then you layer that on top of resource decisions. Who gets the masks that we have? Who gets the ventilators? Who gets the remdesivir? Who gets vaccines first?
And that was the other question. You were at the table for that. So when the vaccines came out, the part that I was interested in is, so we were told that we're going to get the vaccines. And the thought from our team, our local team, was, okay, first we're going to test and see who's got antibodies to make sure that they don't need it, and then start working through it because it's a limited resource.
Yep,
so
exactly.
let's start but instead we threw it at everybody, and we didn't test. So we had no idea who had some complications from this virus itself, who's potentially going to develop it from a vaccine they received. We just basically blanket gave it to everybody. What was the thought process behind doing it that way and not checking for some sort of antibody test first?
Well, you're making me think back, number one. I actually say in the book, one of the challenges or one of the missed opportunities from my standpoint was antibody testing. We should have done more antibody testing. That said, you asked what the thinking in the moment was. The whole reason we do vaccines versus exposing people naturally is because we don't want to encourage people to intentionally harm themselves to get immunity, number one. And number two, when you're exposed naturally, we have no idea what dose you got. When you actually are vaccinating someone, we have tested that we're giving you this amount, and in 90+% of the population, it's going to give you a sufficient antibody response to get the result that we want. And so the challenge that we had with antibody testing, and I still believe that we should have been more aggressive about developing and promoting and using antibody testing, but the challenge we had is that once you have an antibody test, there's a saying, don't do a test in medicine if you don't know what you're going to do with the result. Well, okay, you've got antibodies. Does that mean you don't get vaccinated? We did not have the ability to tell people that. Just now, literally just in the last week, are we starting to get some of the more definitive studies that tell us truly the difference between your protection from from antibodies versus or from naturally derived antibodies versus COVID on a large population scale. So those are the challenges, and that was a lot of the thinking going on. We also had, like I said, political pressure. So you had New York saying, we've been harder hit than you all as a state. We deserve vaccines before Montana gets them. So is it based on the impact of the virus on a state at large? Is it based on the impact of a virus on a particular subset of the community? We know older people were harder hit. So again, that made sense to roll it out to older people first. Is it on the people who are most likely to be exposed? Healthcare workers and frontline workers. So again, all these are questions we were dealing with, and you could make a case for any of those arguments. You should say the hardest hit people should get it first. The people with the highest proportion of COVID cases. You could say the people who are at highest risk if they get COVID should get it. You should say the people with the highest risk of exposure should get it first. And then you have the politics layered on top of it. So we're getting calls from the hospital saying, all of our frontline workers need to get this so we can open up our hospitals as soon as possible. We're getting calls from AARP. All the old people need to get it first. We're getting calls from the governor of New York saying we need to get it first. We're getting calls from the governor of Montana saying, why are you going to screw us over for those city slickers again? And so it made it very difficult. And ultimately, our decision was actually, we're going to give it to the states based on a population level assessment and let the governors decide. That is ultimately what we decided to do, right or wrong, is let the states decide.
So just as we wrap up, we got about 5 minutes left here. What I'd like to ask is, what is the one biggest mistake you think that not you in particular, but we as a community made with COVID? And then what is the one thing you're most proud of that we did?
The one thing that that I'm most proud of is Operation Warp Speed. Bar none, that is the greatest scientific achievement of our lifetimes. It is. I mean, the fastest a vaccine had been developed before that was 6 years. The average was 10 years. We did it in under a year. And according to at least one Lancet article, 10 to 15 million lives were saved because that vaccine was available, which is why it breaks my heart that the rollout and the communication about that vaccine has helped accelerate and drive vaccine hesitancy to the point that we actually are now going backwards on any number of vaccines. It breaks my heart, but I'm proud of that achievement, and I was involved with Operation Warp Speed in terms of recruiting diversity into the clinical trials, helping make sure people could trust, ironically, the vaccine on the back end, particularly people who were hard hit the most. The biggest, I'd say, mistake that we made, I think we didn't, is a mistake I think we make all the time in public health and in medicine. We didn't think about the importance of communication. We were so focused on the science, and the science was literally changing minute by minute by minute, that we didn't think about what to say and how to say it. And the way we said it, in many cases, is what led to a lot of the mistrust and distrust that we have out there. I actually think medical schools and public health schools and health profession schools should have training in communication, both to an individual and to a larger audience. Because if we did, then, well, again, the science doesn't matter if you can't communicate it to people in a way to help them change their behaviors.
You want to close this out?
Yeah. So, we didn't get to a lot, but I want to ask you this one question. So, we didn't get a whole lot into the socioeconomic stuff with, kids staying home from school, all those kinds of things. But in the big picture, what do you see as the 10-year follow-up to that? What are the effects that you can foresee?
Well, I'm frustrated because we are so divided, and that's the reason why I wrote my book. We're so divided that we can't honestly reflect on what went wrong, what went right, and then make a decision to move forward. There's a saying, there's a reason your windshield is about 50 to 100 times bigger than your rearview mirror. We're spending all our time looking in the rearview mirror and pointing fingers and blaming, and not enough time looking at what we do moving forward. Another thing that I will often say is you look at what's happening in Gaza, you look at what's happening in Ukraine, you look at what's happening in Africa every single day. There are kids and people who go through, on a population level, far worse than what most of America went through during COVID, and they're coming out of it stronger than what we're coming out of COVID. So there's something fundamentally wrong. We want to blame it all on COVID. There's something bigger going on here, far bigger going on here. You mentioned a lot of the trade-offs. I think, and I know we've got to close, but an important point, and I like to tell stories. I remember sitting in the Situation Room, and it was my job to give the president the best health recommendations that I could. However, sitting next to me was Betsy DeVos. It was her job to say, this is the impact that decision is going to have on education. Steve Mnuchin, Secretary of Treasury, sitting to the left of me. This is the impact that it's going to have on the economy. And then you had Ben Carson. This is the impact it's going to have on housing, the head of HUD. I say that because it's important to understand that it's easy to say you all made the wrong decision. It's hard to understand that these are multivariate decisions. And if you squeeze the balloon in one place, it's going to pop up in another place. Anyone who's taken any sort of a basic microbiology course would tell you that sending kids to school is going to be a disaster, because you're taking all these kids with a highly infectious disease and cramming them into a location. That was not bad thinking, but we also, and so it was my job to say, based on virology and based on infectious disease and epidemiology, that it's likely to increase spread of the virus. But it's also Betsy DeVos's job to say, but if we keep kids out of school, it's going to cause further harm to them. And so the lesson as we close is that we have to remember that life is a lot more nuanced than what we want to appreciate. It's not black or white. It's not keep all the schools open. It's not shut all the schools down. And it's a good way to reflect back on your question. What was the biggest mistake? This is a problem we have in public health all the time, and I've dealt with many crises. It's hard to figure out what that trigger is when you pull the fire alarm. But once you pull it, it's even harder to figure out when to turn the alarm off. And I still contend that based on the information we had at the time, we made appropriate decisions in the moment. I will defend the decisions we made in the moment, even as I reflect back and say, well, with more information, we shouldn't have done that. But I will also say that the mistake we made is we didn't know or communicate what the off switch was moving forward. And so I think for future disasters and future crises, we need to make sure we've got all the right players at the table, that we're discussing the trade-offs and not just looking at it myopically through one particular lens of education alone, or economy alone, or direct impacts on health alone. And I think that we need to I think leaders need to communicate those trade-offs to the public, and you're still going to have to make a tough decision. I mean, it's still, there's no decision you make that's not going to harm somebody. But we need to understand and be honest about those trade-offs. And then we need to evaluate in hindsight. And that's something that, as I mentioned, we're not doing by looking in the rearview mirror. We need to go back afterwards, because that's science. Science is, here's my hypothesis, here's what we're going to do, and then it's, okay, did we actually get the results that we got? So if we do that, then I think ultimately, and it really is, it's the scientific process. Understand all your variables, understand the information you have, make a decision, test it, and then reflect back. And if it worked, great, do more, scale it up. If it didn't, then change course. If we do that, then I think we'll be in a better place moving forward. But we're failing to do that now because we're so stuck on looking backwards and politicizing and blaming instead of learning and reflecting and improving.
Well, just because you mentioned that, I'll just throw it out there. Because of politics, you were often sometimes unfairly labeled as Trump's Surgeon General, not the United States Surgeon General. So I think that was pretty unfair. But I think we got a really amazing and enlightening glimpse into who you are as a person, and clearly all the work that you've done, which has been, wonderful for the United States. So thank you for being here with us today.
Appreciate the conversation with all of you. I mean, I think, again, these are hard conversations, and we need more of them to happen in a format like this. I know we're out of time, but one of the challenges is a lot of the communication that I did during the pandemic was in a 2-minute CNN or Fox News interview. Sure. You don't have time to get into the nuance. Sure. So I appreciate you all giving me the opportunity, and I appreciate what you all are doing to lead the conversation around some of these more complex topics.
Absolutely. This was our goal. So thank you again. Appreciate it. This was the Medical Brief powered by Surgeon.